Check one, two. Check. Hello, hello.
आदित्य सुन, हाँ मेरी आवाज पोडियम से आ रही है ये अभी। देख अभी मेरी आवाज पोडियम से आ रही है, मेरे मोबाइल को मैंने म्यूट किया हूँ। ठीक है, डन, ओके। कर दिया कर दिया कर दिया कर दिया कर दिया, मूव किया हूँ, देखो। आदित्य ए डिस्प्ले इधर करना, इमरान इमरान पोडियम दे इधर, पोडियम दे इधर। उसी को स्विच रहता है ना, वही तो पोडियम है। ये तो मेरा लगा था। पीपीटी चेंज हुई क्या देख, पीपीटी चेंज हो रही है क्या देख। मेरे पास आ रही है, आया ना, उसके बाद अभी चेंज हुई। हो रही है ना, ठीक है, चलो ओके ओके। अब एक बार देखना, उधर आ रही है आपके पास, क्या दिखा रहा है? उधर आ रही है, ये दिखा रही है, ये दिखा रही है। उधर दिखा रहा था, ये इधर नहीं दिखा रहा था, उधर दिखा रही है। दोबारा एक बार अभी देख ले एक बार वापस से। हाँ मेरे को पीपीटी और ये दोनों सही आ रहा है। सुन सुन, अभी मैं पीपीटी चेंज किया, चेंज हुआ तेरा पीपीटी? हाँ हाँ जूम पे स्विच हो रहा है सर। हाँ हो रहा है। हाँ प्रोडक्शन साइड, आर्ट फिलॉसफी, प्रोडक्ट पोर्टफोलियो, बस ठीक है, डन। चल ओके ओके यही सेटिंग रहने देना, बस ठीक है ठीक है ओके चल। मैं मेरा स्क्रीन शेयर करूं? हां एक करके वाला स्क्रीन शेयर कर देते हैं, बोलोगा स्क्रीन शेयर मेरा कुछ मत कर, वो वहां से कुछ मत कर। अभी ये पोडियम का लगा है, पोडियम पे ही स्क्रीन हो है, वहां से पीपीटी चलेगी अपने आप से। नहीं नहीं मेरा स्क्रीन शेयर अपना लोगो लगा कर, अपना लोगो लगा नहीं, यही लगा रहा है, यही लगा रहा है, वही लगा, वही वाला यही लगा हुआ है हमारा वाला। पोडियम 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 ही है, वही आ रहा है, वही आ रहा है। नहीं पोडियम नहीं आ रहा है, पोडियम तेरा है। हाँ हाँ तो पोडियम से मेरे पास ही तो आ रहा है ना। तो इधर क्यों जूम दिखा रहा है, इधर जूम क्यों दिखा रहा है? वो बाद में नहीं दिखाएगा, बाद में नहीं, अब भी नहीं दिखने का मेरे को। बाद में क्यों नहीं दिखाएगा, अब भी नहीं दिखेगा। नहीं इधर बराबर चल रहा था, इससे पहले बराबर चल रहा था, तेरे इधर भी बराबर चल रहा था, उधर भी। आपका ये है, मेरा ये है। एक मिनट रुक जा, एक मिनट रुक, एक मिनट, तेरा वाला लगा जा। नहीं पोडियम किधर है, पोडियम पहले डायरेक्ट आ रहा था, वो बराबर आ रहा था, अभी चेंज किया तो पोडियम उससे जाने लगा। अभी नीचे क्या दिखा रहा है? नहीं अरे यार वो मैंने बराबर था, रुक जा। नहीं पोडियम ये दे मेरे को, मेरे वाले का स्विच मार देना। हाँ अब इधर बराबर चल रहा है, अभी रुक जा एक मिनट, मैं वापस उसको आदित्य को लेता। नहीं नहीं एक बार चेक कर लेंगे, अभी इसके बाद सिस्टम चेंज नहीं करना, सेटिंग नहीं चेंज करना, इसके बाद अभी चेंज नहीं करना कुछ नहीं। अरे वो एक्चुअली क्या था, मैंने वो विंडो की जगह जूम वाला विंडो ओपन कर दिया, मैं वही बोल रहा हूं देखो, तो उसको उधर से भाई ने देख, एक बार वापस देख ले बराबर आ रहा है क्या इधर थोड़ा। हाँ स्क्रीन शेयर कर, तेरा स्क्रीन शेयर बंद कर, हमारा स्क्रीन शेयर करना। अभी क्या आ रहा है देखो हमारा स्क्रीन शेयर में, अभी हमारे स्क्रीन शेयर में आ जाएगा प्रॉपर। क्या एक मिनट स्क्रीन शेयर कर, हां ईसाई फार्मास्यूटिकल। इधर क्यों आ रहा है ये सब, इधर पे ये नहीं आना चाहिए, ये सिर्फ ये फीड उसको जाना चाहिए, सिर्फ इधर डिस्प्ले पे ये नहीं आना चाहिए। क्या नहीं आना चाहिए? डिस्प्ले पे मेरा ये स्लाइड दिखना चाहिए खाली। वो कोने पे वो क्यों आ रहा है? जूम का है, वो तो दिखेगा ही दिखेगा। अरे कल नहीं दिखा है भाई, देख चेंज हो रहा है क्या? स्लाइड चेंज हो रहा है, ठीक है ठीक है ठीक है ठीक है चल। अगर जूम पे शेयर कर रहा हूँ ना, ये उधर से आ रही है। हाँ उसके उधर का लगा दे, अभी तेरा लगा, तेरा लगा यहाँ पे चार्जर लगा है। ठीक है ना अपना स्टार्ट। हाँ 11 बजेगा, 10:30, एक 2 घंटे का ही है। हाँ वो बस
इसमें चार्जर लगा हुआ है।
First of all, and a short apologies from our side, since this venue is getting live telecasted to across India, to close to 1,000 doctors. So there was some technical glitches, which is now sorted. So with this, my name is Vivek Pandey. I lead the marketing for sleep and multiple sclerosis business for EISAI in India. And it's a truly honor on behalf of EISAI to have you all today on this Saturday evening, specifically when there was a lot of challenges in Delhi and around area till evening 6 o'clock, which is now sort of sorted. So thank you for all of you to have bringing out your valuable time on this Saturday evening and being part of this highly anticipated and truly valuable international speaker program on sleep, which is again remains one of the highly under-diagnosed, under-talked topic in India with the highest, one of the highest prevalence. And whom better to have it today to talk about it than Dr. Felici, who has come all the way, ma'am, from US. And specifically, this is the third location ma'am has been coming daily. Thank you, ma'am, for being there. Welcome once again. With this, I'll just take 2 minutes of your time to introduce what EISAI is and what we actually believe in and why we are doing this program and what actually sets us apart from what we have been doing in the other companies. So to start with, EISAI is a global research and development company based out of Japan at a global office, but at the same time, EISAI, we proudly call ourselves a human healthcare company because whatever we do with patient at the center. And with this, it is now 84 years of anniversary that we are celebrating globally. And we are a very strong global research and development company, basically in neuropsychiatry segment and oncology segment, and now immunology. With this, we are present in close to with 40 subsidiaries across the globe with the support of around 11,000 employees working day in and day out to bring that benefit to the patient. And this And with this, we are not what
video camera in settings.
Neurologist of like to yourself Dr. Vishnu and Dr. Rajesh Ram, who will be moderating. These are the six locations in the overall state. It is introduced see. It's always a pleasure to listen to her each time and say that we go back with some special knowledge. We are all here to nearly full, despite the tensions that we've been experiencing in the last 3 days. And me too. It's really a great honor also for me to visit with my colleagues and also to join this very esteemed panel that will be discussing the issue of sleep. Well, I know we are running late and really lengthy, so we will try to go through this as well as we can so that and I just realized that the time that we're walking in is because there's too much bright light here, so late at night. And one of the things that we studied is that light at night is not good for you. So, especially when you eat and have bright light, that actually affects you. Start by just giving a little bit of an overview of the importance of sleep for health, but also within that framework, how your resting system. So from the very beginning, all quite aware that there was darkness and there was light. So that is so important because the rotation of the Earth on its axis is going to be with activity can be linked in sync with the rotation of the Earth's tremendous daylight cycles. The sleep and wake systems actually evolved much later in biology because there's always a rest and activity that sleep other than sleeping and wake up and feeling the shift. So conceptually, it's very, very simple. Conceptually, there are two major processes that determines the quality of your sleep, quantity of your sleep, and the quality of your sleep. The first one is the cortisol. So from the there's this buildup of either neurotransmitter, protein, it could be a metabolic factor. One of those is a dense builds up. And the longer you move away, almost a linear relationship builds up. And it leads to dissipate during the night. And that dissipation occurs during the night during sleep. This is when we think about REM sleep, non-REM sleep, we think classically of sleep. We're looking mainly at EISAI sleep. But for you to stay awake during the day, and it's pretty late right now, you also need the circadian clock system. And what the circadian clock system is doing.
Right.
So you have the circadian alerting signal. It's counteracting this buildup of sleep drive, the sleep need. Otherwise, we'd be like, they don't have consolidated sleep. They actually really develop circadian system, cat naps. So they sleep like 3 or 4 hours. So it's only the fully satisfied that's determining the amount of sleep. So they're better. Well, around the same time, to eat before maybe a couple hours, 2 or 3 hours before you actually fall asleep, there's a rise of melatonin. Signal comes from these central clocks. It sends a signal to the field, which is melatonin, which decreases the firing of these neurons in the cerebrospinal, producing the nervous. You get buildup of sleep energy, brain, muscles, everywhere. Then during sleeping, the melatonin system dampens the circadian arousal or alerting signals. So it's perfect time that you can get 7 to 8 hours consolidated sleep. Now, the orexin system, which we'll talk a little bit more later, is a neurotransmitter system that's only up during the day, during wakefulness. It's an alerting signal. But it is really a stabilizing alerting signal. So you can conceptualize then that when the interaction of these 3 or 4 systems are not aligned with each other, or one is lower than the other, that they could then result in insomnia or other types of sleep disorders. Age, sex, lifestyle disease can all affect both the homeostatic as well as the circadian system, as well as the orexin system. Now, you could have insomnia because your sleep drive is low during the day. You could also have insomnia because you're sleeping too much during the day. Your wake propensity is low and not driving your sleep drive, homeostatic drive into the night. You can also have low levels of melatonin, which occurs when you get a little bit older. And so that increases in arousal, perhaps during the sleep period, creating a situation of early morning waking. We also have higher levels of orexin, or especially for the sleep. About 52,000 neurons, and it's located mainly in the perifornical area of the lateral. What's really neat about the system is that you can see it's just look over here. Here's the orexin neurons over here. It sends projections to the cortex, but it also projects pathways to all the way mononergic and cholinergic nucleating systems in the brain. So what it's doing, these are all activating systems. So what it's doing is stabilizing the wake state. And low levels of orexin help during the night stabilize sleep state. So it's really a stabilizer of the sleep and wake state, and perhaps the sleep and wake switch. So it projects very well. So all these weight regulating areas. Where sleep, you have to involve another nucleus here called the ventral preoptic nucleus. Is there any? Okay, it's okay. Okay, we'll get pointed to this. It's okay. So you see the ventral preoptic nucleus right here. And this nucleus, when it's activated, it's GABAergic. When it's activated, it inhibits all the weight promoting pathways, regions that you already saw that the orexin system actually activates. So sleep can be thought of as an active inhibition of weight to some in some ways. And that plays into the medications that we use, right? Classically, the medications that we have were GABAergic, whether they're the Z drugs or whether they are the benzodiazepines. And they work in this VLPL system, but of course the receptors for the GABA is very, very widespread. So the orexin protein, there's A or 1, and orexin B or 2, and they sit on they activate the orexin receptors, and again, there's A and B, and these are G coupled proteins. The orexin, both A and B, or 1 and 2, they're involved in sleep and weight regulation, especially weight regulation, but there may be some differences between the 1 and the 2 receptors. For example, the orexin 2 may be more important whereas activation 1 and there's some differences in the DORAs that are available on the market and the relative strength of their binding to these 2 different types of receptors. So could insomnia then be a disorder of either excessive arousal, because orexin levels may be high, although that is not necessarily the case in people with insomnia, that because most of it has not been measured. Or it could be an imbalance between the sleep and weight regulatory systems, which is probably more likely. So again, if you have activation, you have activation of the gas, it promotes sleep or GABA. Is that it is stable sleep and wake states. It's like patients with narcolepsy. They can't stay awake, stay. However, they also have sleep application during the night. So it's really a stable. It itself is not a stimulation. It's not a stimulant. It's really more, I think, a stabilizer indirectly at least distance. It also projects, in addition to the sleep wake centers, such as wake centers, it also has receptors in the, for example, prefrontal cortex, involved in attention, maybe even cognition of the orexin system, but also look at all these other areas, the nucleus accumbens, right? So you're thinking about reward, abuse liability here. This is the lateral thalamus, amygdala, emotional regulation, balance, again, memory, consolidation, this area, and then also cognition and memory learning. So these are all areas that are being studied mostly in animal models right now of what the orexin system may be doing. So this is the same thing for us as clinicians, but there may be potential implications. For example, would this drug, would the orexin target be better for in patients with comorbid stress or anxiety? So stress response modulation, pain modulation, reward addiction, feeding, weight regulation. I didn't talk about that. So the word orexin comes from orexigenic, it's appetite, it's eating. So cardiometabolic function, cognition, and can go on. So you can see there's really broad potential implications of when you manipulate the orexin system. So I'm going to show you about 3 or so slides of areas that are under investigation. That when you look at sleep, there's often morbid insomnia, depression. So this in these conditions, what happens is that with low concentration of orexin, but they have that actually stimulates the serotonergic system, whereas the opposite high levels, it actually inhibits the serotonergic system. Now, these are animal studies, these are associations, they're not directional, does not mean that the orexin system is involved, or it's part of depression or bipolar disease. It could very well just be a secondary maybe they have insomnia, so the orexin levels are high, or could be a compensatory mechanism that is transient where the orexin levels may be high. But there's some data out there, especially with depression and bipolar disease, that in patients with bipolar disease, particularly, it may have high levels of shaking our head, we don't know. But so it makes sense that maybe you do want to keep that to some extent. But its the picture for this is not as clear either. I've looked at other studies, and some of them have found lower levels of orexin in patients with depression, higher levels, maybe whether these are active in patients who are in high activity with depression, or those who are more depressive part. And I think, it could just be a compensatory. So what about sleep and anxiety? Look at where these neurons project to. They project to areas that regulate mood, anxiety, stress responses as well. And so actually, it could also have a role in some of these comorbid conditions. And there's some research. I think the data is fairly, I would say, in general, weak. There's some signals out there that there may be increased orexin plasma levels in anxiety. Plasma orexin is probably not a great assay, so I would salt. You can see over here that in patients with anxiety, primary anxiety disorder, that there was elevation in the plasma levels. Again, this could be a compensatory mechanism, not necessarily part of the disease process itself. This is an area of great interest because remember, it projects your nucleus accumbens, right? So when you stimulate orexin, it's going to stimulate the nucleus accumbens as well. And so low levels of that, you're probably less likely to be substance abuse or addiction. So there may be a role of this in patients with insomnia who you are concerned about either history of substance use or as you're getting them off or decreasing their substance or withdrawing them from substance. This is a bit of a data showing that during the relapse, orexin levels are higher in the in plasma, and once they during recovery in a few weeks, they actually it goes down. So it's like to me, it's really active phenomenon. But yet, it may be helpful for us in using some of these DORAs. Is used to help the sleep in patients to prevent relapse. This is where I think most of the strength of the data the system comes into is in neurodegenerative disorders such as Alzheimer's disease. And to a little less and strong overexpression is associated a DORA, orexin antagonist, was able to decrease the CSF levels. This is work that's done by the Washington University group, Bader Holtzman, and his colleagues. So orexin receptor antagonism essentially can maybe effective in these older adults, perhaps people with MCI, who are at risk for developing Alzheimer's disease. There's been 2 studies using DORAs, one with osteoborexin and the other with naporexin in patients with Alzheimer's disease as well. And they shown to be effective at students. Here, instead of looking at plasma levels, Ligori looked at the CSF levels in the spinal cord, which is much, much better assay. And you can see that in patients with Alzheimer's disease, and depending on the severity, that there's a relationship between increased levels of orexin levels and that of the cognitive dysfunction in this group. The data, again, is there. However, some other groups may not have been able to replicate this. And I think it's because it's highly dependent on the severity of the disease. So in Parkinson's disease, you see the same thing. Plasma levels are elevated in patients with Parkinson's disease. But I want you to look at this part here. This is for those patients with severe Parkinson's disease. So I think it may be just a response, and it depends on the state of the neurodegeneration, because eventually it will be low. So that can happen. So now let's talk about insomnia itself, which is the topic here. For those of you who are sleep specialists, I apologize because this is clearly a review. I want to say that it is a disease in its own right, but it's really very, very commonly comorbid with other medical and psychiatric disorders. That it can be a standalone disease by itself. It requires chronicity and frequency more than three or more months and 3 or more nights per week. And it has to be not due to sleep deprivation. So you have to ask your patient, how many hours are you in bed? Are you trying to sleep? If they're only in bed for 5 hours, they're sleeping for 4 hours or 5 hours, they don't have insomnia. Daytime symptoms is a purely clinical diagnosis, and difficulty falling asleep, difficulty staying asleep, early morning awakening could be that, or just dissatisfaction with their sleep quality and performance. Daytime impairment can take many forms. It could be fatigue. Insomnia are not really sleepy per se, except the older adults. They tend to be tired and fatigued. Mood disorders can be comorbid. It can also affect mood. They may be behavior difficulties and lack of concentration. And in older people, some of this actually looks like they have dementia, right? Or early dementia because they have cognitive concerns. Insomnia is a 24-hour problem and a 24-hour disorder. Although we tend to focus during the night, all the medications, most of them focus on the outcome measures of total sleep time and sleep quality, but we need to really pay attention to the daytime symptoms as well. I will not be speaking on the cognitive behavioral therapy for insomnia, so I just want to keep this slide up for a few minutes. That it is the first line treatment for insomnia disorder, and this is true for comorbid insomnia with medical psychiatric conditions as well. Whether you're looking at the American College of Physicians, European guidelines, pretty much global guidelines, it's that CBTI should be used either as a first line alone and or in combination with medications or pharmacotherapy. I don't use pharmacotherapy alone without cognitive behavioral therapy. There are web-based cognitive behavioral therapies. One of them that you can look at, I think it should be available to you, is CBTI Coach. It's the VA system. It's free, and I tell my patients to start using that to start with. So if we look at pharmacological therapy, we want to improve the sleep abnormalities, but we also want to improve daytime function, right? And we also want to minimize the side effects. I think that it's safe to say that we've had very efficacious drugs for insomnia, but it is a safety profile that I think that has changed over the last several years. This is a systematic review. It's a network analysis of both and also meta-analysis of 47 plus individuals. Various medications have been used for the treatment of insomnia in various publications and study. So you look at the short-term efficacy, 4 weeks or less, you can see that almost all the medications, even some of the antidepressants, they are all efficacious. They favor the drug, except for the, I guess, the bottom ones there, let's just pronounce that. Now, if you look at the 3-month or longer studies, when the studies were done with placebo-controlled 3 months or longer, here you can see that azopiclone is coming, and you don't have azopiclone here in India, you have zopiclone, right? This is the isomer. And then also naproxen came out over here. So in the longer term studies, and it doesn't mean that the others didn't really work, it just means that also that with these drugs, there were long-term studies. There were 3-month studies or even longer studies than that. But safety, what about safety? Well, imidazole, some of the things that we use very commonly for cyclic sense. The benzodiazepine medications, the Z drugs, they have a higher side effect profile. And for example, if you compare to the DORAs, in the US with 3 DORAs, and as well as Romelcan. So if you look at all the other agents, other than the benzodiazepines and these and Z drugs, pathway, assuming that maybe that Good evening, and thank you very much for coming on a Friday evening, and it's probably going to be very late. It is indeed my pleasure to be here. My first time in the city of Joy, and I already had your sweet curd, which was very, very delicious. And I am very honored to be joined by my very esteemed colleagues in neurology and psychiatry. I'd like to thank EISAI for sponsoring me here in India. So what I thought I would do today is to give you a bit of an overview of the neurobiology of sleep and wake regulation and how the orexin system and how an orexin antagonist may play an important role in treating insomnia, and perhaps also disorders are often comorbid with insomnia, such as many of the neuropsychiatric disorders. So I will start by something that why we're all here is because we all sleep. So from the very, very beginning, there was the rotation of the earth on its axis. And therefore, the development of circadian rhythms so that your biology as an organism, whether you're plant or bacteria, you have to be synchronized to this rotation of the earth, this tremendously strong light and dark cycles. Hence, much later in evolution, we develop sleep and wake. It is the same: rest, activity. Cockroach sleep as well. They have rest activity. They don't have EEG, but they still have this metabolically rest period and active period. And we have begun to know that sleep and circadian rhythms together, they regulate bioenergetics at the cellular level, at the molecular level, even mitochondrial metabolism, for example, and cellular metabolism. So when you lack sleep or you have very disturbed sleep, it increases your risk for multiple medical and psychiatric and neurological conditions. Of course, recently, a lot about inflammation. Sleep is hugely important in the area of immune regulation and inflammation. What we tend to know mostly is that of sleep and wake. So when there's light, we are active. We're supposed to be active. And during the evening, during the night time period, supposed to be sleeping. But in our modern society, we get lights all the time. Like right now, it's light at night here. We also eat at various times of the day that may be not good for our health and not in sync. So your sleep-wake timing is not in sync with your other behaviors and also with your own internal circadian rhythms. More recently, I think it's been very exciting, at least for certainly neurologists, where it's beginning to pay attention, is that sleep is a risk factor for many neurological disorders, and particularly the neurodegenerative disorders. And this is just a video of the lymphatic flow in imaging, MRI imaging, where you can see this 1 hertz per second pulsations. It is not your heartbeat. Each of these pulsations is preceded by a slow wave during sleep, and it's thought to be flushing out the large molecules like A-beta amyloid or tau that builds up in the brain in patients with Alzheimer's disease, and thus is part of the pathobiology of Alzheimer's disease. So you can see that sleep is playing more than just keeping you awake and making you happy during the day. It's playing a very important role in the clearance of byproducts. So conceptually, when we think about what regulates sleep and the timing of sleep, the amount of sleep, the quality of sleep, we think of two systems. One is the sleep homeostatic system. So this is kind of conceptually a neurotransmitter or a protein that builds up during the day from the time that you wake up. So it's homeostatically regulated. It gets more and more as the day progresses, the longer you're awake. And during the night, it dissipates so that the brain now is ready to wake up and also wake up and do the activities and metabolic activities. But at the same time, and we have the circadian clock system. The center of the circadian clock is in the hypothalamus, in the area called the suprachiasmatic nucleus. And during the day, it's producing this alerting signal. So when these neurons are firing, usually during the light period, it's producing an alerting signal that counteracts this tremendous buildup of the need for sleep during the day. So it is this interaction between these two systems that determines how awake you are going to be during the day and how sleepy you will be during the night. With that also comes then melatonin that is secreted by the pineal gland. And melatonin, when it's secreted in the evening, light blocks it, but when it's secreted in the evening during the night, it actually decreases the firing rate of these neurons in the suprachiasmatic nucleus, and thus permits, it's not a hypnotic, does not make you fall asleep. It permits sleep, the homeostatic drive, to actually dissipate during the night. Now, during the day, and one of the important wake-promoting agents is the orexin system. So the orexin system is high during the day and low during the night. There's a small amount of tone during the night, but it's quite low. At a time, really, they intersect. Orexins go down, melatonin begins to go up. So you can see it's a perfect synchrony and harmony of high homeostatic drive because you've been awake all day, the circadian system shutting down a bit, and also the orexin system shutting down. Of course, age, older people have more insomnia, for example. There's sex differences in insomnia and sleep disorders. Lifestyle diseases can certainly affect sleep and wake function. So how do they do that? They can either decrease the homeostatic drive for sleep. They could decrease the propensity for wakefulness, like low orexin levels, for example, or too high orexin levels can then cause this imbalance between the sleep and wake systems. And also we know with aging, there's a decrease in the amount of melatonin that is being secreted by the pineal gland because it calcifies mostly. So we think that maybe a high level of activating neurotransmitters and low levels, for example, maybe of something like melatonin or other sleep-promoting molecules could explain this insomnia, both sleep onset insomnia as well as sleep maintenance insomnia. So how many of you drink coffee or take tea? No? No, come on. Yes, of course. So one of the homeostatic transmitters is adenosine, and caffeine is an adenosine receptor antagonist. So caffeine is working through the homeostatic mechanism. Melatonin is working through the chronobiotic or through the circadian mechanism. So just give you an idea how these things can be used. So we're going to focus now on the orexin system, but also on sleep and wake regulation. These orexin neurons there are only about 50,000 to 80,000 orexin producing neurons in the hypothalamus and also in the posterior hypothalamus. So a very small number of neurons. When you look at the pathways that are activated during wakefulness, or what we call activation, you can see right here. Oops. Change. Oops. When all of these things are activated, you can see these are the mononergic systems, the dopaminergic, the cholinergic nuclei in the brainstem, the reticular activating formation here. They're activated, they activate the cortex. Now, here's the little neurons of the orexin system right here, and look where they also project. The orexin system projects to all the mononergic systems as well as the cholinergic systems. So what it's doing is stabilizing the wake state. It's not norepinephrine, it's not dopamine, okay, but it's stabilizing the wake state because it's projecting, activating all of these systems together. Now, when you look at sleep, on the other hand, it is the opposite. There's this little nuclei here called a ventrolateral preoptic nucleus, discovered, both orexin and the VLPO was discovered in 1999, okay, 1999. And here it's projecting where? The same areas that the orexin system is projecting to these mononergic nuclei, as well as some of the cholinergic centers. So when that nuclei is activated, the VLPO, ventrolateral preoptic nucleus, it inhibits the wake promoting system. So you've got the orexin system activating the wake promoting system. You've got this ventrolateral preoptic nucleus, which is mainly GABAergic, but it also is galaninergic, so also responds to the molecule galanine. So you can think of sleep then as an active inhibition of wake. And so you need both of these systems to be in play like a seesaw so that you can stay awake in a stable manner during the day and also sleep in a consolidated manner during the night. So the orexin protein here, you have orexin A, you have orexin B, or 1 and 2. And they sit on these two different receptors, 1 and 2. They're G activated proteins. Receptors, I'm sorry. Both types of orexin play a role in sleep and wake regulation, particularly in wake regulation. However, there's some differences between the two. If you look at the orexin 2 receptor, it may have a more of a role in regulating the wake to non-REM transitions as compared to one system, which may be more important in the wake REM transitions and also from REM sleep to REM sleep transitions. But you can see both of them are important to various degrees in this regulation. So it's thought that then overactivation, especially during the sleep period, of the orexin receptors or the orexin system itself may be responsible for some of the insomnia that we see in patients. This is theoretical. Measuring orexin in the CSF of insomnia patients has not really been consistent, not all that we know of, but this is a theoretical model. So we can think then of insomnia as a disorder of arousal or perhaps an imbalance between the sleep and wake regulatory systems. So when we think about this and we're looking, I think I can point, does this work? Oh, yeah, this works, it's perfect. So if you think about wake, then you want to activate the monoaminergic system, norepinephrine, histamine, dopamine, serotonin, and acetylcholine. And that then, when it's activated, promotes wake. The orexin system activates the system to promote wakefulness, but to stabilize wakefulness during the day. Whereas the GABA system over here in galanine from the ventrolateral preoptic nucleus actually inhibits the orexin system, right? So you can see that this is a cycle of a balance between neurotransmitters, neuropharmacology that promotes wakefulness, and as I said earlier, stabilizes both wake and sleep. Patients with narcolepsy can't stay awake during the day. They fall into these sleep attacks during the day, but they also have fragmented sleep at night. So because they lack the neurotransmitter orexin. Oops, did I do that? So orexin receptors are involved, as I said earlier, or the orexin pathway in sleep and wake regulation. But because the orexin, in addition to the areas in the monoaminergic system that I just mentioned, it also projects to other areas, not projects, there's receptors in other areas of the brain, such as the prefrontal cortex and area near the insula. I think most interesting with the anterior cingulate gyrus, hippocampus. So you can see these are areas that are involved in some of the neuropsychiatric regulation of anxiety, for example, stress responses, and also learning and memory. So it potentially can have broader effects. And in fact, this is a slide by Tom Scammell, who shows that if you look at the orexin system as a whole, you have these inputs. You have afferent nuclei, right? Sleep and wake is one of them. It feeds sleep and wake, but you have also the circadian system. It's a beautiful diurnal rhythm, high during the day and low during the night of the orexin system, orexin levels. And also you can see that there's also other functions. It also is involved in stress response and feeding. The word orexin comes from orexigenic feeding. It was originally thought to be an appetite regulating molecule, which it is, but it was then later found that it also regulated sleep and wake. What's important is that these afferents then go into the orexin nuclei, these neurons, and then they send these pathways to the target nuclei, which I already mentioned earlier. So when you look at this area, the target nuclei are involved potentially the orexin system in stress response modulation and pain modulation and reward addiction, feeding and weight regulation, cardiometabolic function through the autonomic regulation that it has, respiration as well. I forgot to include that, cardiometabolic function, cognition, mood, and I'll show you a little bit of data in neurodegeneration. So it's a very, very important system for neuroscience overall. I'm going to show you a couple of examples that I do not want you to take home the message that the orexin system is involved in the pathobiology or physiology of neuropsychiatric disorders such as neurodegeneration or depression. But because the comorbid insomnia is so common among these conditions, and there's some evidence that in some of these conditions, the orexin levels are actually increased in some of these patients, that it makes sense that an orexin antagonist may be useful. So the best data that I know of right now is in neurodegenerative disorders, and particularly that of Alzheimer's disease. if you look at animal studies and mice studies, you can see that orexin overexpression is associated with higher levels of A beta amyloid accumulation, as well as accumulation of the tau protein. And that if you give a orexin antagonist, one of the DORAs, you can actually decrease the CSF levels of these of A beta amyloid. So there's something I think that's a very, very interesting concept, that there may be involved overactivity of the orexin system because you're not sleeping could actually decrease lymphatic flow, for example. So the orexin antagonist, as I said earlier, has also been studied in patients with Alzheimer's disease, mainly for their sleep and circadian effects. There's also data this is the CSF data, cerebrospinal fluid data, that there is a relationship between, in patients with Alzheimer's disease, and the degree of severity with the degree of the elevation of orexin A, I believe it was, in the CSF of these individuals. So there's some evidence that orexin system may also be elevated in these patients with Alzheimer's disease. There's also evolving data in people with Parkinson's disease. In the early stages of Parkinson's disease, as you can see over here, there is also an increase in the amount of orexin in the plasma. This was not in the CSF. However, I think it's interesting to note that if now you go down to the patients with more severe Parkinson's disease, now there's a lower amount of orexin in the plasma. So it could be mainly something that is in response to the disease rather than part of the disease process itself. Depression is very commonly comorbid with insomnia, as well as bipolar disorder. There's some data and also in animal studies that low concentrations of the low levels of orexin is associated with also some increases or excitation of the serotonergic neurons. This is again in animal studies. So you can hypothesize potentially that when serotonin is low, orexin may actually go up, right? May actually go up as a compensatory mechanism, and therefore may contribute to the insomnia that's often comorbid in these patients, and thus again potentially a mechanism that we can use in the in this bidirectional relationship between insomnia and depression. And there is indeed some data in the literature that indicates that in patients with bipolar disease, this is in adolescents, that there's also an increase, as you can see, in the plasma levels of orexin in these individuals. It is mainly, interestingly enough, I think it's even more pronounced here in patients with bipolar disease. It's even higher in patients with bipolar disease. But I want to also, to be balanced, that the evidence is mixed. Some studies found lower levels, and there's questions about the reliability of plasma orexin assays. Maybe it's just the comorbidity, right? Maybe it's the sleep or the insomnia comorbidity rather than the disease itself. And my hypothesis is that we see these elevations potentially as compensatory mechanisms associated with the sleep disturbance that we see. Anxiety disorder also. Look at the projection of the orexin neurons to these areas. These are stress-regulating areas, anxiety and stress-regulating neurons here, or nuclei. So they project to these regions, and there's, again, some data showing that there's increased orexin plasma levels in patients with anxiety, and you can see that here as well. Again, chicken or egg, I don't know, but this seemed to make sense that they have insomnia, they have anxiety, that maybe a DORA could be potentially effective. Here's something that I think is very interesting, because based on the orexin system, if your orexin level is low, it's very hard to have addiction. That's just patients with narcolepsy hardly ever get addicted to anything because they actually don't have the effects on the nucleus accumbens. So this is potentially a very interesting medication in that one can potentially think about using in patients who have substance use or when we're withdrawing them from that. And this is just another piece of data showing that when they're trying to, in patients with alcohol dependence, they're treating for relapse prevention, that they found that during the relapse, those with the higher orexin levels were more likely to relapse than those who were not. And so again, potentially, this is just a hypothesis that maybe orexin could be a target also in patients that you're treating, especially during the withdrawal period. So let's talk about insomnia disorder. It's a clinical diagnosis for all of you. There's no sleep study that you need to do for this, but it's important to note that it's a disease in its own right. It is not secondary to or due to Parkinson's disease or depression. It is often comorbid. Insomnia predicts the risk for depression even 10, 15 years later, okay? So it's often comorbid. Now, can it exist as part of depression? Absolutely. It can also be secondary to that. It requires at least 3 nights or more of having insomnia per week and for 3 or more months chronically. And it's very important that your patients are not there because they're only allowing themselves 5 or 6 hours of time in bed, okay? That is sleep restriction, and that is not insomnia. So they are trying to sleep. They're staying in bed for 7 to 8 hours, and they still can't sleep. They have to have symptoms of difficulty initiating sleep, difficulty maintaining sleep, early morning awakening, or just dissatisfaction with their sleep, and must be accompanied by impairment of daytime function. So a patient that comes and says to me, "Doctor, I think I only sleep 6 hours and I wake up 2 times, I sleep 7 hours, I wake 2 or 3 times, and I feel fine during the day, I have no problems, my weight is good, my cognition is good." They don't have insomnia disorder, okay? It is also a 24-hour disorder. We always call these sleep disorders, but I would say they're sleep-wake disorders. There are nighttime symptoms that we look at, but think about the daytime symptoms, the impaired concentration, impaired mood, behavior, work, and what you do during the day is what builds up that homeostatic system that I just talked about earlier. So if physical exercise, light, what you do, what you eat, your level of stress from the day, that all goes into the night. So for your patients, very, very important to think about those things. I will not be talking about cognitive behavior therapy because we really do not have time for that. Rather, I will focus on pharmacotherapy, but I want you to, it's very, very important, the slide, that when you look at any guideline in the United States and in Europe and pretty much across the world, the management of chronic insomnia, the first line therapy is cognitive behavior therapy, which includes sleep hygiene, but it's more than sleep hygiene. And that in the US, we tend to say you can either use a pharmacotherapy with cognitive behavior therapy, or you use cognitive behavior therapy alone, but never, really, almost never, without at least cognitive behavior therapy if you're going to use pharmacotherapy, because you can use cognitive behavior therapy to taper people off of medications. So when we look at pharmacotherapy, what do we want in a drug? We want it to improve sleep latency, increase total sleep time, decrease wake time after sleep, and overall the patient says, my sleep is good, of good quality. We also want to improve daytime function. So this is something new, and many trials until very recently have not really looked at what happens during the day to these patients, only at the sleep, and very importantly, to minimize the side effects of the medications. And I think that this is the advance that we've had in the last 5+ years, is really minimizing the side effects in addition to maintaining, or in some cases improving, the efficacy of the older medications. This is a meta-analysis, systematic review and meta-analysis that was done in about studies that include 47,850 participants. And what it shows here on the left is a forest plot, right, of these various medications that we commonly use in the treatment of insomnia, right? All of these, you can see some of those are the Z drugs, some of those are the Z drugs, and some of those are some of the things that we use that are like antidepressants. What I think is important to note is that they all work in the short term, right? This is the 4-week period, except for the lower ones here, and there's quetiapine and Rameltian, for example, here. Now, if you look at 3 months or longer, the one that comes up is lemborexant as favoring the drug rather than placebo. This is for efficacy, right? This is for efficacy, as well as azopiclone, which you don't have here in India. You have zopiclone, which is, I think, somewhat similar to that. Now, what about safety? So if you look at safety of some of the, like trimipramine and the Z drugs and also the Z drugs, you can see that actually it favors placebo. So there are concerns about the safety profile of these medications. And safety included falls, included AEs. So this was all things that they looked at in this meta-analysis. Whereas if you look at the DORAs, all the DORAs, we have 3 DORAs in the United States. If you look at the DORAs and the other agents like melatonin, doxepin, and even zaleplon, which is a very short-acting Z drug, they were not significantly different in their safety profile from that of placebo in the placebo trials. So when this study, they balancing the long-term efficacy, not the short-term, long-term efficacy, tolerability, and safety, lemborexant was more favorable than azopiclone, which was the medication that had the better long-term efficacy. So let's talk about the orexin system in insomnia. We already talked about this a little bit, just to remind you that the orexin system is believed to be activator, hyperactive in some patients with insomnia, and therefore it makes sense to dampen the arousal system, the orexin system in patients with insomnia. So I think this represents really one of the only new paradigms shift in the pharmacological treatment in the last 10 or so years. They've always been GABAergic type of medications, some more specific for some subunits of the GABA receptor, but in general, very much taking that VLPO and shutting it down, so inhibiting sleep actively. So lemborexant is a dual orexin receptor antagonist. So I will only talk about lemborexant because that's what you have available here in India that has been approved. And I wanted just to show you that it is fairly selective. All of the pathway, there's receptors in various areas of the brain. Lemborexant does not interact in vitro with these, or does not bind to GABA receptors, benzodiazepine receptors, serotonergic receptors. So it's very specific receptor binding in these various regions. And so it does then make sense, perhaps that can explain a bit of their safety profile. I will not also go very in detail in any of the trial data because you may have already seen some of this, but there's been 2 trials that are pivotal trials called Sunrise 1 and Sunrise 2 in patients with insomnia for lemborexant, and it helped improve sleep onset latency, lemborexant, and this was compared to placebo and zolpidem. Okay, it was compared to zolpidem, although it was a lower dose zolpidem, but it was compared to zolpidem as an active control. So it was significantly improved even compared to zolpidem. Most subjects on lemborexant fell asleep in less than 25 minutes, and improvements, I think important, in lemborexant was noted as early as 1 week and persisted over a 12-month period in Sunrise 2. Sleep maintenance, it helps patients stay asleep compared to placebo and zolpidem. And they gain almost depending on the study, 50 to 60 minutes more of sleep, decrease in wake after sleep onset, which is quite substantial. And this was true for both the PSG, so the EEG, the objective recording of sleep, as well as self-reported improvements in these patients. And again, lasted for up to about 12 months. Importantly, when you look at daytime function, it improved daytime fatigue compared to placebo and And I think it's also important to note that when you look at subjective ratings of the severity of insomnia, it was favorable to lemborexant decrease the severity of insomnia. It sometimes did not get rid of all of the insomnia, but certainly improved that. This is just a little bit of the data just to show you that either the 5 or 10 milligram over here, they perform very similarly in this shorter term. This is the PSG, it's the EEG study. And the same thing if you look at sleep efficiency, right? You can see that here, sleep efficiency over here. So they're close. There's some differences at the beginning, but after about 30 days, they begin to narrow between these two, the 5 and 10 milligrams. This is the 12-month study. This is a 6-month placebo-controlled portion right here. And then patients were then at the beginning, maybe I should just the beginning, and then they were allowed then to cross over, and those who are on the placebo could continue then on the active drug. And you can see that the wake after sleep onset, as well as all the other sleep parameters, were maintained at the 12-month period. Safety, what about next day function? I talked about daytime fatigue. There was no next day morning residual effects on cognition. Fall risk, there was really no increase in sway compared to as measured. You can see, I'll show you the data in a little bit, as well as no significant or clinically meaningful effect on driving performance. It's something that in the US, the FDA always makes you do, the driving performance. So we always do that. Here's a balance study. And in the active control, the active study, it compared to zolpidem, as you can see over here. Zolpidem in the middle of the night, lots of body balance issues, whereas you can see this with the 5 and 10 milligrams of the lemborexant. You can see this also in the bottom. This is the driving study. This is looking at lane deviation, the standard deviation, lane deviation. And the bottom line is compared to zolpidem here. This was not a comparison with zolpidem, but zolpidem, flunitrazepam, and ramelteon, there was impaired driving performance in those, and lemborexant had no statistically clinically significant change. So it's safe as far as balance is concerned and motor, motor, I guess, psychomotor activity. So are there then insomnia subtypes? Is everybody going to benefit? Well, when they did the trials, they didn't take any subtypes. They took everybody who met the criteria for clinical insomnia disorder. But are there some specific subtypes based on the orexin system? It is my speculation, but based on the role of maintaining stable, prolonged periods of wakefulness during the day, that then allows, of course, the homeostat to rise and increase during the day and dissipate during the night. I could think that maybe those with hyperarousal and also those with anxiety, the patients with insomnia say to you, I can't shut my brain down, I can't shut my brain down, right? The other group would be people with circadian disorders, like shift workers. They have activation of their orexin when they're trying to sleep during the day. So perhaps dampening down could be useful. These are not FDA approved indications specifically, but I think about those when I am seeing some of my patients just based on the mechanism. What about based on the afferents and efferents, the outputs of the orexin neurons? It maybe patients with anxiety, stress, comorbid. It's not treating the stress, but the insomnia is comorbid with anxiety disorders, with mood disorders, also in patients with substance abuse or history of substance abuse, where you have concerns about the Z drugs and or the benzodiazepines. Patients with neurodegenerative disorders, I say older adults where safety and special balance issues and memory issues may be of concern. And there's also some data now in chronic pain that I do not show, because in chronic pain, there may be also activation of the
of the brain areas, maybe of the monoaminergic system, and the orexin antagonist may help. So we're going to go through two very brief exercises. This is a 65-year-old female with difficulty falling asleep and staying asleep for several years, but more severe in the past 8 months. She's a little bit overweight. Typical for the U.S., this is a little bit overweight. Typically takes 1 to 2 hours to fall asleep and wakes up at 3 or 4 times during the night. Just can't seem to shut her mind down at bedtime. She has a history of anxiety and depression, treated with sertraline, and has common migraine. Recently diagnosed with possible mild cognitive impairment. She just has, her memory is not very good, and maybe you have MCI. She has migraines, but it has been more frequent more recently since her insomnia. She also gets up 2 times during the night to go to the bathroom. She has mild sleep apnea, and she's been taking Zolpidem 5 milligrams. And because she couldn't stay asleep with 5 milligrams, they changed it to Zolpidem 6.5 milligrams, the CR or the long-acting version, the control-release version. And it helps her kind of fall asleep, but she's still waking up after 3 hours and having difficulty staying asleep. And the doctor here, she came to me with this. The doctor did not increase her to a higher dose of the Zolpidem, probably because she's female, and in the U.S. it's only indicated at 5 milligrams for women, and so the lower dose. So the concerns here, well, she's concerned she may be getting Alzheimer's disease, and we have plenty of data, very strong data, that sleep fragmentation, insomnia-like symptoms can predict our risk factors for the development of cognitive impairment and Alzheimer's disease 6 or more years before the clinical diagnosis. That could be because of the lymphatic system that we talked about a little bit earlier. What about depression? She has comorbid depression. And there's very strong data, and this is just a forest plot of several studies that show that depression itself is a risk factor for, depression. Insomnia itself is a risk factor for the development of depression, again, prospectively when you look at this. So, here are some of the considerations in this patient. She's got difficulty falling asleep and staying asleep. So you need something that's going to help her do that. Daytime function. She has mood, anxiety, depression, stress. Nocturia. She gets up in the middle of the night. So balance is a potential issue, and she has mild sleep apnea. So take a second or maybe 1 minute and think, what would you do? Assuming that we will all do cognitive behavior therapy. Okay, let's assume that. What would you do? Well, what about behavioral and cognitive therapy? Absolutely. I did a DORA trial, indicated because it can help her for sleep onset and sleep maintenance insomnia. Had a favorable safety profile for balance in the middle of the night, and also not likely to affect her sleep apnea. It's mild, but it's been studied in people with sleep apnea, whereas the benzodiazepines may be more of a problem. Now, another question that maybe you can think for just a second, how are you going to do that? She's on Zolpidem, right? So what are you going to do? Are you going to switch taper or cross taper with Zolpidem? Just think what you would normally do. So let's look now at some data. So there is actually a study that was done with Zolpidem to lemborexant, not crossing over. It's a switch study. There were 3 cohorts. Basically, either those were taking Zolpidem intermittently, those were taking it frequently, and at the 5 and 10 milligrams. So the bottom line is when they just stopped it. Okay, in the study, they stopped it. No tapering, they just stopped it. And you can see the data here. But 81.1% successfully transitioned from lemborexant, intermittent or frequent dosing of Zolpidem. At the end of the treatment, more lemborexant group reported that it helped them fall back to sleep compared to Zolpidem. And the safety profile, as you should always look at the prescribing information, because I'm not talking about the safety profile other than the positive, but there are side effects like sleep paralysis, and maybe vivid dreaming, and also not daytime sleepiness, but morning sleepiness upon awakening. So this is another study where they did a little bit differently. This is not a EISAI sponsored study. This is an independent study. They took people 5 milligrams or adjusted so they were able to titrate to 10 milligrams of lemborexin. So the different kinds of patients on Z-drugs, patients on other like suvorexin, patients on other medications. So different kind of mixed medications. And what they did was they looked at the 1 week and they looked at also the 2 week. The primary endpoint was how many patients were able to successfully transition to lemborexin at 2 weeks. And you can see that they not always just stopped it. They also had, for example, with some of the Z drugs, they also had a tapering schedule as they were increasing it to the 10 milligrams. 95.6% transition, very similar to the other study. And most of the patients who transitioned continued on the lemborexin. And the satisfaction and safety were evaluated at 14 weeks, and it was as you would expect for lemborexin. Next, a 52-year-old female with difficulty falling asleep for about 3 years, and more recently also difficulty staying asleep. She used to take Zolpidem 5 milligrams for about a year. Then 3 months ago was increased to 10 milligrams, but still having trouble staying asleep. Bedtime is 11:30, wakes up at 7:30, so she's in bed for 8 hours. Okay, Zolpidem 10 milligrams, falls asleep in less than 1 hour, but wakes up 2 to 3 times per night, and it takes her a lot of time to fall back to sleep. Her PCP said, okay, I'm going to add trazodone 50 milligrams. And then it was increased to 100 milligrams to help maintain sleep. Now, he's waking up feeling not refreshed, feels that it's affecting his performance at work. It's probably helping him stay asleep, but he's not very happy with the side effect profile. He has also a history of alcohol abuse, but it stopped 4 years ago. He's been very dry since then, and no other really significant medications other than using melatonin intermittently. So here's a patient who's taking a BZRA and trazodone, which is not uncommon in my practice, intermittent melatonin, history of substance abuse. What would you do? What do you think are some of the considerations here? Increase the trazodone, decrease the BZRA. I mean, there's so many possibilities, right? So cognitive behavior therapy, extremely important. I started a trial of Adora, in this case, lemborexin. In some other cases, I may start because I have other choices in the United States. But then the question is, switch, taper off, or cross taper? What do I do with trazodone if I'm going to take this patient, taper them off or take them off of the Zolpidem? What about, should I let them use the BZRA during their taper or not? So these are all the considerations that I'm sure all of you are also thinking about, right? So think about, what would you do first? What would be, of all of these choices, what would you think you would do first? So we could do this, right? Because you stop the Zolpidem, continue trazodone, add lemborexin, 5 milligrams. We could stop both Zolpidem and trazodone and just add lemborexin and just titrate lemborexin to 10 milligrams, very similar to what that study that I showed you earlier did. Or we taper Zolpidem and we taper trazodone, and then we add the lemborexin. So this is when we say cross tapering, right? So we're cross tapering for a period of time. I don't know what you chose, but this is what I did, and it's not right or wrong. I just decided to do this, and sometimes it doesn't work, so I have to go backwards to one of these other methods. So we tapered off Zolpidem to 5 milligrams. He was taking 10 for 2 to 3 weeks, very, very slowly, then even further down. Started lemborexin pretty much at the same time, 5 milligrams, and titrated up to 10 milligrams over probably a 2-month period, actually, while I was also tapering trazodone all at the same time. So I'm tapering both at the same time. I just halved everything. And then I was able to stop the trazodone at 2 weeks. So that's what we did. And I also allowed this patient, because he was very anxious, to have a little bit of zolpidem at his bedside if he needed it, so that he could use it intermittently if he was having difficulty falling asleep, or for that matter, mainly falling asleep at that time. So I'm going to go and end by saying that this is really an era, the beginning of the era of precision medicine for insomnia. We really did not have this armamentum of different mechanisms. It is often comorbid with medical and psychiatric conditions, so it's very important to think about what mechanism to use in patients who have comorbid conditions. I think it's also really important to think about lifestyle and behavioral components, very, very important as part of the overall management of patients with insomnia. Ask about their environment, their bedroom, light at night, devices that they're looking at while before they go to sleep, meal timing. I recommend try to stop eating 2 to 3 hours before you go to bed. It's okay to eat late, like you're going to eat late, but you probably won't be able to go to bed until midnight tonight. And then also consider pharmacotherapy when needed. But first, look at the things that you may be able to manage behaviorally or on a cognitive basis. So our goals of treatment, of course, is to improve sleep quality in all of its domains. And what I think we're looking at the future is, if we're able to improve sleep is so important in a risk factor for the development of neurodegeneration, of metabolic and cardiovascular disorders, could early treatment of insomnia help mitigate the development and or the expression, or at least the severity of some of these comorbid conditions? And I think that that's where we're pretty much at. I think we now need to look in the future at, data and research on the effectiveness and safety of the DORAs in insomnia that's comorbid with neurological, psychiatric, and cardiometabolic disorders. It makes sense to use them, but I think we really need that data in patient populations to really feel very comfortable, but also to know which patients will likely benefit the most from this type of a mechanism. So finally, I want to say that the future, as we say, looks good, that maybe there will be a role for the orexin antagonists in neuropsychiatric disorders, insomnia, comorbid neuropsychiatric disorders, in neurodegeneration. I did not mention delirium, but there's some really good clinical data on delirium right now that it seems like you would think that their delirium, nothing else works, and yet the orexin antagonist seems to work. This is, of course, just from clinicians. These are not based on trial data. And finally, a lot of people are also looking at this in relation to cardiovascular and metabolic disorders. So sleep is a health imperative. It is a risk factor for most disorders that we know of. And also, if you look at sleep is still under-recognized. So if you're in the blue country, you are recognized. That means you have a lot of data on sleep health in your country. But India is in the green. You have a little bit of data. So go out there and make sleep a priority. And I thank you. It's been an honor to share this information with you.